All right, am I live? Oh my God, I've been live for like 3 seconds. Hey there, good afternoon, guys. What's going on? It's Hoang here. I am on Facebook, I'm on YouTube, I'm on Instagram. So I'm excited to be here with you this Saturday. Actually, our family did a little getaway. So I'm in this little town, this little sleepy town called Melbourne, Florida. So it's just 3 hours north of where we live and where I have my clinic and my businesses. So welcome to our beach condo. As you see my sign, my favorite drink is my next one. Cheers. So it is Wine and Hoang because I just wanted, it's a very relaxed, informal place where I can come on and talk to you. So say hi, hello. We're going to talk about flexor tendons. We've been talking about flexor tendons. Well, it's like a never-ending conversation about flexor tendons. Am I right here? We can talk about flexor tendons all day. And it's funny because in like as I'm teaching in the hand exam prep and everyone's comparing the old edition to the new seventh edition as they're studying, I think when it comes to flexor tendons, I think there has been the most amount of changes when it comes to flexor tendons out of all the topics that we could talk about. I think the most progressive has been our flexor tendon treatments, because the way surgeries are changing allows therapy to change along with it. Um, so yeah, say hi, type into the chat, let me know you're here, let me know what you want to talk about. And if you like anything that I'm saying, definitely give me some likes and some hearts if you're on Instagram. So yeah, let me know where you are tuning in from. I love to hear and talk to everyone, no matter where you are in the world. And it's funny because in the program, we have been able to reach people. Yeah, yes, that's right. We're talking about flexor tendons. It cracks me up, you guys. It cracks me up every time I talk about flexor tendons or extensor tendon. I'm like, which one? I do have a favorite. But every single time I want to talk about tendons, there's this like sometimes one edges over the other, and this time, I mean, it was almost like this neck to neck. Every time I'm thinking, yeah, extensor tendons, flexor tendon be like flexor tendons. So all you flexor tendons, thank you for voting because that's what I'm talking about today. And I'm not gonna talk to you about the same shit you guys already know, like the flexor tendon. The anatomy is here, and I think the biggest thing when it comes to talking about tendons is what you're not finding, right? You're not finding how to get over the fear of treating with flexor tendons. I think people are, as therapists, scared to treat flexor tendons. And I want to help you essentially work through some of those fears because your patients need you. Your patients need you to not be fearful. Your patients need you to really know what's going on so you can take them through the next levels over and over and over again. Oh, very good. You're from New York and you're studying for the November CHA exam. Kudos to you. Yes, that's very exciting. We always, in the hand exam prep, we always have people, funny enough, from all over. We get a lot of East Coast people, we get tons of West Coast people, and then we also get them internationally too. So this program is an international program, and every single time we open for enrollment, we get people with interest and people who sign up from all over the world. So it's really exciting to think about how, like I'm, I was once there studying for that CHT. I was once there, like, how do I help more people in my area? And this platform here at Hand Therapy Seekers is just to help even more people. Like, never would have thought that I'd reach someone like you in New York, right? And then, but if I can help you kind of, change a little bit about how you're thinking about flexor tendons, like, imagine all the people that you're going to be able to help and influence in your area, right? In your area. So it's amazing to be able to help more and more people that are just not in Miami, right? So my clinic, I'm based out of Miami, Florida. Just in case you guys didn't know, I'm based out of Miami, Florida. My private clinic is there. Majority of my experience comes from hospital-based experience. So I learned a lot of the things that I do now, like a ton of it, from the hospital. Like, when I show wound care cases or when I talk about wound care, it's because I had all this experience when I was working for someone else, in hospital-based places, and then I was able to move from those hospital-based places into a hospital outpatient place into a private practice, and then onto my own. So I think no matter where you are in your path to becoming a certified hand therapist, um, to becoming an expert in your area, essentially, flexor tendons are one of those injuries, one of those cases that need a lot of our attention, right? They need a lot of our attention, and there is. So I'm going to spend a lot of my time today talking about getting over that fear and, like, what do you need to do, and some treatment strategies around that. So if you have any specific comments, any specific questions, by all means, go ahead and type into the chat. And if you like anything that I'm saying, go ahead and like, and you can let some of your other friends know that I'm getting ready to get started to talk, and maybe they can join you in this as well. So when I talk to, whether it be new grads, new therapists, right? Um, People studying for their CHT, people who are already CHTs, people who are already experienced, there's always something as it pertains to flexor tendons. And it's okay to have a little bit of that. It's okay to have a little bit of that fear, a little bit of that doubt, right? But at the end of the day, when I talk about becoming a critical thinker, problem solver, and decision maker, it's because at the end of the day, you, as the expert, you have to, patients are coming to you because they need your expertise, right? They are scared. Your patients are scared. Your patient is scared. Your patients are frustrated, and they're afraid, right? They're afraid. They're looking up the same things you're looking up. They're looking up that there can be ruptures. They're looking up that they can get stuck. They're looking up that what it takes, and so you're going to run the gamut of, like, who knows what when it comes to flexor tendons. But regardless of their fears and their concerns, you have to always step up to the plate and be less fearful of treating flexor tendons than they are, or at least take action, right? So when it comes to, I had asked this question in the stories, in the Instagram stories, a couple of days ago, in terms of, what scares you about flexor tendons. Can you type into chat, like, what scares you about flexor tendons? So the two choices I gave people were, are you scared because it might rupture, or are you scared because you won't get the progress that you're hoping for, right? So there's usually two fears associated with flexor tendons. And one is that it's going to rupture, and two, that there's no progress. And a therapist mentioned in the DM that says, she was like, I guess it would depend on your experience, right? And to a certain extent, it does depend on your experience. But I think that in the hand therapy world, there's been a long time talk of ruptures, and there's so much inherent blame when it comes to therapists that we somehow take all the blame for a rupture. And in order to sort of get over that fear of rupturing, let me explain a little bit about that rupture, right? So one, if someone cuts their tendon and they go to the doctor to get it sewn back together, right? Because tendons need to, for the most part, be sewn together. There's a lot more detail and intricacies, like why something wouldn't get ruptured, why something wouldn't get repaired, right? And it goes a little bit into a lot more, goes into a lot more detail. Sorry, it goes into a lot more detail for why. But for the most part, there you always want to have that repair and repaired as soon as possible, right? And there's a lot of technique in that repair. So surgeons have to do a really good job of making sure that when they put those two tendons together, that there's a certain amount of like bunch, like they're a little overlapped and bunched together, right? Because then there's a certain amount of glide that needs to happen in the flexor tendons. I think in the flexor tendons, unlike any other tendons, even the extensor tendons, the flexor tendons for a certain amount of the finger is in this sheath, right? And it's in that sheath that there's a certain amount of I don't want to say fluid, but a certain amount of substance that needs to be created so that that tendon can glide, and then it has to glide separately of each other, right? So you have your your superficialis and your profundus, and they have to glide together, and then they have to glide separately, right? So when the doctors put that together, they have to be put together in a certain way, and then it has to it has to be strong enough. So that's their job. That's their job. And sometimes in doing their job, it's not done in as well as it could be. Let's just put it like that, right? There's If you're studying for the hand exam prep, you'll know that, I mean, sorry, if you're studying for the CHT exam in the 7th edition, they really talk about, one of the doctors that wrote that chapter really talks about the wide awake approach. Like I first heard about that when I first became a certified hand therapist. I went to this lecture. I think we talked about it. I heard about it initially like 15 years ago, right? And then now it's just slowly but surely. Things take time, things take time to like kind of move, right? So now you're just hearing about it more. There's a lot more changes in terms of saying, well, if the surgery wasn't done correctly, sometimes this gap in between the tendons, and that's what can contribute to lack of progress. There can be what contribute to ruptures, right? So that's one aspect of rupture or no progress. Then you have your component as the therapist to know exactly what happened, right? You need to know how strong that repair is. To a certain extent, having a good relationship with that surgeon, or using it as a way of creating a better relationship and letting them know that you know what you're doing, right? So in order to be able to do that, you have to have that belief that you can treat flexor tendons. So that belief has to come in first in order for you to say, like, send those flexor tendons to me, you know? So you develop that relationship, you nurture that relationship so that you can know exactly what's going on. But I can tell you right now, even without knowing the surgeon or knowing exactly what's going on, I can, through my experience, but through knowing anatomy, kinematics, and all that good stuff, you can break down that information and know exactly what you need to do and when you need to do it, right? You can literally learn to take a look at a scar and say, based on where that scar is, and da 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 da, and check movements, and check tendons, and through your evaluation process, know what's going on, so that you can know what's next. Oh, date of injury, date of surgery, right? So you can know. So in one part, you have the surgeon's job, and then you have your job, and then part of your job is to make sure that you communicate in a way that patients know what their job is, right? So you have to do your job really, really well so that your patients, clients know their job. So that's the third component. So doctor's job, your job. So you want to essentially communicate if you can with them, right? And then your job here is to then communicate with your patients in a certain way that they understand what their job is. And it makes me feel some kind of way when people are like, I'm so tired of having to say the same thing. Dude, that's your job. Your job is to say the same thing over and over and over, and until someone understands or until someone takes action, right? That's your job. Now, if someone is not understanding you or they're not taking action, then you have to go back to yourself and say, is there something I'm saying or doing, or something I'm not saying or not doing that that person doesn't understand, right? That's your job. So part of your job in terms of educating them is to say, okay, hey, based on your type of surgery, based on what I'm seeing today in the evaluation, here is what you're allowed to do, and here is what you are not allowed to do. I actually had my whole career, knock on wood, never had a rupture, right? Until this one time. Hold on, let me take a sip of my wine. Cheers. Let me tell you what I'm drinking. It's the morning. I hope it's the morning for you. So I'm drinking one of my favorites, Sauvignon Blanc. It's a Whitehaven, which is a New Zealand brand. It's a New Zealand brand of Sauvignon Blanc. Hey, Cindy, what's going on? Okay, so I don't know your name. Tufano12. Can I call you just Stephanie, just in case? There are a lot of different protocols for flexor tendon repairs. What is the most commonly used protocol today? And could you speak about the different orthoses? Well, there's really kind of just one orthosis. Cheers, Cindy. I love having drinks with you. We'll have to do it again soon. Well, I just love drinks, period. But my favorite drink is my next one. Cindy, I know you like that sign. Don't be trying to steal my sign. There's a lot of protocols. Correct. There's a lot of protocols. The thing is, so because I know a little bit about, yes, Stephanie, yes, I'm a good guesser, man. Sometimes. So when it comes to studying for the exam, because I know that you're studying for the exam, you have to know a lot of shit. Sorry, you gotta pass the exam. So you have to learn all of them essentially. In my program, I kind of run down into different. One of the things I like to do is I like to chunk it up so that we can take the overwhelm out of it, right? So you're gonna have to, if you're not in the program, you're just gonna have to do it to yourself, for yourself, and have chunk up that information. But what you have to learn for the exam is on the next level, right? But if you are treating, and you're trying to get your hours, get your years so that you can do what Stephanie is doing right now, which is to study, then you have to have a different conversation, which is, I need to get over my fear of treating flexor tendons. I know tons of people who are studying for the CHC exam who have not yet had like a flexor tendon repair. They're not always like there. I mean, we can't, you shouldn't hope for people, cutting their tendons. It's a terrible thing, right? But over a period of time, if you go and you know what you're supposed to do, you'll have a chance to practice, right? So in terms of speaking just for treatment, even within the treatment, there are a lot of protocols. And there's teaching in my program, I talk about like the old school protocols and then now the new ones, right? So with the wide awake approach, a lot more people are saying, oh, with a wide awake approach, we're fixing it. We can see that there's no gaps and stuff like that. And the surgery is a strong repair. Go ahead and start moving it. And then you're like, holy crap. But then they're writing, maybe people still want you to do the Duran protocol, right? Modified Duran protocol, which then if we're talking about the splints, you're always going to put them into a little bit of wrist extension. The MP joints and the IP joints are essentially the same in terms of some flexion and IP extension, right? But the new protocol, the newer protocols, and they're talking about the wide awake approach, will actually really put the wrist into some extension, right? And allow early motion. Before you can even treat and make a decision, right? I always talk about critical thinking, problem solving, and making a decision, right? So you need to be able to know the problem. You need to be able to critically think through what's going on and problem solve and then make a decision. So you have to essentially know your zones, right? And one of the easiest things that I like to do, instead of going from 1, 2, 3, 4, 5, I just go and I say, okay, if this is zone, if this is zone 2, we all know this is zone 2, then where are all the other zones, right? Where are all the other zones? 1, 2, and then, let's say you're not exactly sure where the 3s are, or the 4s are, then you can then divide, right? 2, 3, 4, 5, right? So you want to be able to critically think through those and know, okay, based on its location, what are some of the complications, right? So that's just kind of critically thinking through, what you've got in front of you, so that you can make a decision on what protocol. Now, there's some doctors who tell you exactly which protocol that they want, right? And you can either follow that, or after a certain amount of studying, practice, and time, building that confidence of like, I know what really works, then you can actually go and have a conversation around hey, I really like this kind of protocol, and this has really worked for me. Active, early active protocol versus an early passive protocol. So I think I kind of lost track because I was trying to, kind of go into a little bit of the different protocols and which is commonly used. I think in textbook wise, you'll see like more and more people trying to move into that wide awake, wrist into extension, early active, get going further faster. But I think they're in practice, in real life practice, I think that there's still a lot of people doing a more early passive motion, which is the most common one was the modified Duran, which is, wrist into some flexion and then the MPs in flexion, IPs into extension, right? For the most part. So I would say those are the two most, commonly, that protocol is the most common protocol. And if you look, there's a lot of different names of different protocols, but that just makes people's lives really complicated, doesn't it? It's like the same thing. If you look and compare, it's like the same thing, just with different names, right? So first, when it comes to treating flexor tendons, first, in order to even treat them, you've got to shift your thinking and your fear around, well, I can't treat it until I have done it like a million times, right? One thing is you've got to get over that fear. Two is you've got to get over the fear of like the ruptures, right? Understand that there's a doctor's component, there's your component, and then there's the patient's component. And let me tell you about the patient component, okay? Because that was the only time I had a rupture. She actually came to me post-surgical and used to where I would get them post-surgical right from the doctor's office. I would do the post-op dressing. So 3 to 5 days after their surgery, I would see them for their post-op dressing change. So they come in, see the big bulky change, cut it off, take off the thing, take a look at the incision, all that good stuff, and then we would clean the incision. We would create the orthosis. So back then, I did a lot more of the modified Duran, wrist and slight flexion, MP and flexion, IPs and extension. Well, this woman came to me. She was a little bit older, and she came in like half her bandage was hanging off, like she was in a fight with people. And I was like, "What happened? What happened to your splint?" She goes, "I don't know. I woke up like this." I woke up like, I don't know. One day the dressing was on, the next day I woke up like this. She was an older woman, and after her surgery was having a response to the anesthesia, I think. And it wasn't until much later that the family started to admit to me that she was already having some memory issues. But when you ask about stuff, when you spoke to her, she, you know, alert and oriented times three, right? Knew her name, where she was, date, all that. Talk about, oh yeah, I was just here, sounded lucid. But what happened was she was already having some memory issues, and I think the anesthesia kind of like triggered that a little bit more, that dementia coming out. So she fought with her post-op dressing, which meant she was fighting inside. So we were able to see, like, from that her tendon wasn't gliding. So I was able to call down. So I'm like, I don't think that tendon is intact anymore, because this is how she came in. I wasn't seeing anything. And then, so, okay, we're going to keep trying for 2 weeks and see if there's anything. Nothing. So we kept trying for, several more weeks, and still nothing, no change. Passive range of motion, great, was getting better, but nothing active. And so, the doctor can do such a great job. You can do such a great job. But then some people, the patients themselves, if there's something going on that you don't know about, they might have ruptured it. Or if they're not understanding the situation of a flexor tendon. I mean, how many times I've had people where I sit and explain, I say it every single time. And sometimes people are like, yeah, you said this. I'm like, okay, that's okay. My job is to keep saying the same things over and over, because I just want to make sure that you understand, and that I do my due diligence of helping you to understand that when it comes to flexor tendons, they have a tendency to get stuck. So sometimes you might think, oh, I'm going to take the day off because I'm tired today. Like, I deserve the day off. Well, sorry, when you have a flexor tendon injury, you deserve the time off. But you know what? You deserve a lot more than a time off, is you deserve a working hand, and to not have the risk of having another surgery, right? So it takes 5 minutes. This is what you need to do every hour, every 2 hours, depending on what is going on with them. Right. So those are the three components of treating, when it comes to treating flexor tendons, right? When it comes to treating flexor tendons, and being able to a certain extent, getting over that fear of treating flexor tendons. All right. Anthony, I'm an OT student in my second field work rotation in hands. Yay! I have 6 weeks left, and some of your videos have definitely helped me. Much appreciated. Thank you. Anthony, thank you so much for watching. I really hope you have a wonderful time in your rotation. Students, if you are in those rotations, get the most out of it, because let me tell you, when I did mine, I just wanted to treat as much as possible, so that when I came out of school, I can say, yes, I have worked with this, and this, right? That's how you can hopefully get a job afterwards and build your career. No matter if you decide you want to do hands, if you decide you want to go in another direction for a little while before you dive into hands, right? So, yeah. So first, in order to be able to treat flexor tendons, do not bypass this idea that you have to have a certain mindset. Some people, and I know that maybe I didn't see it as important back then as I understand it now because of being able to talk to so many therapists, that there's this inherent fear that it comes to treating, and somehow they talk themselves out of being able to treat. So if you are one of those people who are talking yourself out of treating flexor tendons, this is why you won't ever treat flexor tendons, or why you cannot get over that fear of treating them, right? So because you're, for the most part, you're just not going to rupture them. You're just not. Unless you really F it up, you're not going to rupture them. I think the worst thing, which was the second fear, is the no progress. That's a second fear, the no progress, right? So it's about being really realistic about that progress. That's going to be really important, right? So let's get down to just some simple anatomy. So we know our zones, right? We know our flexor tendons. Start in the elbow and go to the hand, and we have a sheath that wraps around it that allows it to glide, right? And so when we're talking about, and I'm going to talk about in general protocols, is that when we are thinking about flexor tendons, the protocols are, for the most part, like again, I'm going to simplify it. Early passive, so all you're allowed to do is passive range of motion, and then the newer programs that allow more active range of motion, early active range of motion, right? But the safest thing that you can always do is understand anatomy. If you understand anatomy, then you can explain it to your patients and they'll be able to understand anatomy, right? So why are the risks when it comes to flexor tendons, unlike extensor tendons, always going to be essentially the same splint? So Stephanie, you have this question. I'm answering it. I hope you're still here. The splint. The splint is always, for the most part, a dorsal block orthosis. The only thing that changes is the position of the wrist, MP, and IP, depending on the type of surgery, depending on the type of injury and the protocol that is your favorite or your surgeon's favorite, right? It's always going to include a wrist. Why does it always include the wrist? Because you got two main flexor tendons, the superficialis and the profundus, and they both start out in the elbow past the wrist. So if it passes your wrist, you have to include it, right? If it passes your MP, you have to include it, all right? So that's why the splint actually, Stephanie, you hear me? There's one splint. That's it. So that's the easy part. That's the easy part as it pertains to studying, right? In real world, real life, when you're treating that person and you got to make that splint, okay, wipe the sweat and the worry off your face and make the splint. It's actually, the position is, for the most part, right? If you're talking about fingers, why? You need to know why all fingers need to be included. Why all fingers need to be included, because that is something you have to really educate your patients with. Because sometimes they'd be like, well, I didn't cut that finger. I can do whatever I want. No, sir. No, sir. One muscle, 4 tendons. So we got to include all those fingers, right? We got to include all those fingers. And so the wrist, for the most part, if you're going old school, it's going to be like a little bit of flexion. If you're a little bit of a rebel, I'll make that neutral. All right. I think the biggest mistake with flexor tendons is putting them into too much flexion because of fear. Again, of fear. If you're too afraid, you're gonna put that wrist into too much flexion, and it really does like slow you down a little bit, right? So you can put it into 0. If if you are a lot more progressive, right, that wrist is going to go and be in a little bit more of extension. Do you see my fingers? Do you see my MPs? They're going to be flexed. My IPs are going to be extended. It needs to be extended. All right. And so that is knowing your anatomy. And because you know your anatomy, then you're going to be able to apply it no matter if you know that protocol or you're not like, oh my God, not really sure. And this person just walked into my clinic. You're going to know what to do. Slow down, take a deep breath, so that you're not fearful, and you're going to know, because I know my anatomy, I'm going to know that regardless, I need to make a splint that includes the wrist, right? And if you need to fix it later at the next visit, it's okay. Fix it next time. You're like, oh, I went home and I'm like looking at the protocols now, and I'm like looking at my splint after I made it, and I'm like, oh, I don't know if it's I don't know if it's quite right. Fix it. That's all right. Look, listen, I'm just gonna make a few little changes to make your splint fit better, progress you a little bit further, and just make sure you're not stuck. Right. So that's the biggest thing. You got to make that splint. Right. So once you make that splint, then if you get them early, you've got to talk about wound care. I hate getting patients that come in with a crusty wound. Right? Crusty wound. Let's wash that sucker up. Let's clean it up. One of the things that I like saying is I like my wounds to look nice and pretty, right? When you can help promote wound healing, it's going to minimize scarring, right? So Cheryl, I know you love flexor tendons, but you probably also love flexor tendons because you're such an experienced CHT, right? But I can tell you, when I first started, oh my God, flexor tendons did scare me. Flexor tendons did scare me. And I think my fear was more from the stories that people told me versus than anything that I had ever messed up on. So be careful with the stories that you're hearing. Be careful with the stories that you're taking on as your own, right? And this is the whole point of this conversation, is that fear-based talk between therapists and CHTs being like, you can't treat this until you're a CHT. But then again, how do you become a CHT if you're not getting those experiences, right? If you're not studying on those and getting some of those experiences to become one. It's a huge thing. So it's not that you have to become one first to treat them. It's like you have to do that. You have to know how to do that job before you get that job, right? You have to be that hand therapist, be that critical thinker, decision maker before you become that critical thinker, decision maker with some letters behind your name. Right? And it is all about scar management. You got to manage that scar. So, but how do you manage that scar? You've got to manage that scar only once you close it. I have had patients come in who, when they go to a therapist who is fear-based, right? You're afraid. And they leave the incisions scabby, crusty, right? And it doesn't heal, and you can't progress them, and it's a problem, becomes a problem. So if you're not sure what to do, definitely consider reaching out to people, someone with experience, right? Reaching out to someone with experience is the whole point of why we created the kinds of programs we created, because we want people to not be so fear-based, and we want people to be like, oh my God, I had this come in and help me think through it so I can become that independent critical thinker. Yeah, I'm looking at that scar, looks crusty, I'm going to clean it. It looks dry, it looks like it's healing well. Let me remove some of that debris, right? It's time to remove the stitches because I want to be able to move the arm better, the hand better, the finger better, right? And then because that wound closed, and I can work on the scar management, the edema. You can do all the massaging that you want. People love, like hand therapists, that love their massage, like massage the shit out of it, teach your patients. But really, the most impactful way to affect scar, hands down, will always be movement. It is through, if you look through what helps scars are helped through constant movement and stress. So it's through motion, it's through passive motion, it's through active motion, it's all that stuff that will impact at the end of the day scar management. Information downloading. What is your best suggestions for helping soften up scabs that linger? Well, you gotta soften them. So that goes into a whole conversation on wounds, right? Which is a little bit out of the scope of today's talk. But if you have like a hard scab that's lingering, you gotta soften it with there's different ways of softening, depends on the level and the the position of what the wound looks like. So not really sure where that level is, so I can give you more specifics, but scars don't like to be really dry, and then you want to move, right? Whatever you cannot see under, you do not know the level of healing. Just say it like that. Sina, dancer, I'm in a cast that's kind of loose. Is that normal? So, I don't know, because I don't know your predicament. If you are the person with the hand injury, then it's most important for you to reach out to your specialist, whether it be your doctor or therapist, when it comes to a cast. So a cast has got to fit well for its purpose, right? It's got to fit well for its purpose. So I don't know your purpose right now of fitting in that cast, but you don't want to be so tight like it's strangling you, but you don't want it to be so loose that it's letting you move way too much, right? So I'm going to keep it that simplified. Yeah, you don't want anything to be too tight. So I'm going to bring it back to flexor tendons, right? I'm going to bring it back to the talk on flexor tendons, and say that if it's just like when you're making a splint, right? So usually someone who has a flexor tendon, your patients, like if you're the therapist and your patient is in a splint, because usually with a flexor tendon, you wouldn't necessarily put them in a cast, right? For the most part, you wouldn't put, unless they were a child or someone who couldn't follow the rules of the game of flexor tendons, because you need to move, you need to do some passive motion, right? So if the splint is too tight, it's too loose, it's painful, then that person might not wear it the way they're supposed to wear it. So, if you are the therapist, you want to make sure that you're double checking, you're asking about that orthosis. Somebody is wearing that splint for 6 weeks. If they're wearing it for 6 weeks, that thing better well be comfortable. If it's not comfortable, they're going to start coming out of it. They're not going to be wearing it right. So yeah, definitely pay attention to that, right? So we talked about the splints, we talked about wound care, and then we talked about, okay, so let's talk about getting it moving, right? So I have just a few minutes left, and we're talking about it moving. So if you want more details in terms of like step by step how to move somebody, then you consider joining the hand therapy mentorship, because this month we're still talking about flexor tendons, and next week's call is going to be pretty much just that. Flexor tendons, like how do you progress them from week to week to week, right? So if you are fortunate and your patient who comes to you as the specialist, as an occupational therapist, as a certified hand therapist, as a physical therapist who specializes in hands, if they're coming to you early on, you are lucky to get them started in the way that you want to get them started, right? Let's be honest, the world that we live in is not perfect. I just had on Instagram somebody who is here who asked about, well, I was left in my cast for way too long, right? And it really doesn't matter when they come to you, your patients come to you, that is the right time. That is when they need to come to you, right? Yeah, so what? It was, we always talk as therapists, as specialists, we're always like, oh, but they came so late. And, if only I had them earlier. Well, we can't change the past. We just can't. We can't change the past. I'm going to talk about present. What can I do right now? If you're coming in at 3 weeks, if you're coming in at 4 weeks, if you're coming in 6 weeks, what is the position of your hand right now? And that's where I'm going to get started with, right? So if they're coming in, if you know the protocol is, depending on when you get started, you're allowed to do passive range of motion first and then start doing some early active, right? So depending on your protocol, you might start some early active at 2 weeks, at 3 weeks, and then progressively increase 4 weeks, 5 weeks, 6 weeks. By 6 weeks, look at my eyeballs, they're like bulging out because I'm like, listen. Listen, at 6 weeks, we gotta be moving. We gotta the ideal thing is if you have good passive range motion, no pain at 6 weeks, then you're gonna start coming out of it and you're gonna be able to move more, right? You're gonna be able to do your hook fist, your full fist, your straight fist, right? And then over a period of time, gonna crank that sucker out because we need to be able to pull that tendon. Muscles and tendons only get long and short. So they get real long, they get real short, right? For the most part. But if they're only moving this much, you're gonna still have pain because your muscles and tendons want to move all the way, right? All its potential. You want to be able to move it. So by 6 weeks, you want to be moving them along out of their splint. And the decision-making process that as a specialist you should be able to do is to make that determination based on how they feel, their joints, right? So I was teaching the other day and I was like, you gotta remember. And sometimes when I'm talking, I'll like close my eyes, like, to show you a visual. But I was thinking, like, that's kind of creepy. If you're a hand therapist, like that's a little creepy. That don't sit there and be like trying to remember stuff and like close your eyes, because as a hand therapist working with hands, it's a really intimate type of position. You're like literally holding someone's hands the whole time. Don't close your eyes, please. It's a little creepy. So what you want to be able to do is make those decisions about like, can I move them a little bit earlier? Do I need to slow them down a little bit, right? These are critical decision-making processes that you, as an expert, need to be able to make. If someone comes into me at 4 weeks and they're really stuck, I need to be like, based on what I'm seeing, based on how I'm feeling, how I want to be able to progress you due to the injury that you have, I may move you faster. Because you came in late, we got to catch up. We got to catch up, right? Now, if you're coming in at 4 weeks, but you're feeling still pretty good, like, man, we caught up in a day, like you need that splint. Even if it's 2 weeks, they need to be put in that dorsal block orthosis, right? You can't just be like, oh, you came late, it's okay. You know what? It's too expensive for you. We're not going to go do the trouble. No, put them in the orthosis because if they do something too strong, too hard, too fast, and they rupture, it's still on you too, right? It's on them, but it's on you too, right? Don't be cheap about it. Don't make assumptions about that. Like, this is what you need, even if it's for 2 weeks, because they might need to wear a little bit longer at night, depending on what's going on, right? But if they're coming in at 6 weeks and you're like, man, you don't need to be in that. But most of the time, if they're coming to you at 6 weeks, they may not need that dorsal block orthosis. They might need something else because they're going to be stiff as a board most of the time if they've come to you and they haven't received any other therapy, right? Thanks, Melinda, for watching. She said thanks for the guidance. All right, so Stephanie, how common is bowstringing after flexor tendon repairs? How, as therapists, can we prevent this? Well, we really can't. Bowstringing is actually not very common after flexor tendon repairs. Bowstringing happens because the sheath that I was talking about, imagine the sheath as a condom, right? Because let's face it, it's kind of weird, and it ripped. uh, so now the tendon's not staying where it's supposed to be, right? How are you gonna stop it? It's torn. It's like saying, how can I put back a ruptured tendon? You can't, right? You can't. So bowstringing happens because those pulleys and those cruciate ligaments, cruciate ligaments are your crisscross pulleys. I mean, your crisscross ligaments, and then your pulleys are the ones that just go across. Like the most common one that we know about is so in order to remember exactly where they are, you can bend your finger, and wherever your crease is, that's where your your MC ends and your P1 starts. And so your A1 pulley is right here, right? So you want to, you need to know that your pulleys, if they cut in certain places, that your pulleys were repaired if they were cut, right, for the most part. But the surgeons fix that part too, because again, it's essentially a type of connective tissue, right? Like a ligament. If it's cut or torn, it's usually cut. You can't do anything but have it repaired. Um, Does it happen more in the thumb than in the finger? Not necessarily. So in the thumb, it's, they have a very similar pulley cruciate ligament too. So then it becomes a matter of understanding which one is important, right? Which one's important to keep those tendons there. It's not very common. Do you need to know some of that? Yes. If you're starting out, so again, where are you on your journey of becoming that hand expert? Right? If you're starting out and you're trying to get those treatments, you need to get that experience, then you just need to know that this is repaired. I need to know the protocol. I need to know how to move them, and then become really confident about how you're moving them. There's a certain memory that you have to have, that as you learn, as you practice with your patients, your finger, this is how I describe it. It's the only way I describe it, right? Is that you have to remember how someone feels when you're working with them. So you can take them from one visit to the next, or from one patient to the next, right? So you kind of have to have a little bit of both of that, so that you can understand, and so you can remember how something feels, so you can know what to do the next time, right? So yeah. So that's flexor tendons. So really, at the end of the day, when it comes to flexor tendons, you want to, one, work on essentially it's self-limiting beliefs, right? Self-limiting beliefs that stories that are told that create more fear, or make that fear stick in terms of how you're treating, or can you treat, or if you can treat, and when you can treat, right? So a certain amount of the self-belief have to be dealt with, so you can be like, me, I can treat flexor tendons, me, send them my way, me, I know how to do that type of job, right? One, to get through that so that you can have a chance of treating. And then two, then it becomes like you want to go over simplified anatomy, right? Simplified anatomy, so that you can then take the protocols that because if you know a certain amount of anatomy, you're going to be able to know the protocols. And the protocols are going to include that splinting, that wound care, like when to move, how to fast to move, right? And that's how you essentially build up all your experience, so that you can become that decision maker, problem solver that I talk about, right? Decision maker, big thing. And that, at the end of the day, right, that at the end of the day is applied knowledge. I talk about that all day, every day, all day, every day in my programs, right? All day, every day in my programs. I can tell you right now, if you're sitting there and you're only going and you're only trying to memorize anatomy, you're only going and trying to memorize protocols, you're missing a very, very vital component, which is like applying that knowledge that you know, right? Huge. It's through that applied knowledge that you get to practice and you get to improve your patients' lives, right? And then because you're doing that, then you're going to be so much more motivated, right? So much more compelled to be like, man, I want to then elevate that knowledge. And then it's this revolving circle of just building up your skills and experience, right? So that you can be an expert. I can tell you right now that this hand therapy secrets is a channel, right? Is a channel to help more and more occupational therapists become specialized. Help more and more occupational therapists become certified hand therapists, right? And physical therapists, right? Because there's a small percentage of physical therapists that they love hand therapy and they want to special. Every single time I open my program, I've got a PC in there being like, hey Hoang, I really want to become specialized in hand therapy. And they join and they do it, right? So it's not, it's not so simple as just memorizing, please, because your patients, right? Your patients are coming onto this channel to learn what they need to do. Right? I get people on, messaging us. I get people who come on live and answer their medical questions. I'm very careful because I don't like to give out information that I don't like to give out information that I know nothing of, right? Really, it's very irresponsible. So when people ask me, oh, but tell me what to do, I can't. I don't know you. I don't know what happened to you. I don't know what you've done. I don't know what you've been through. I don't know the surgery. Like, so it's irresponsible of me to just be like, oh yeah, you got this, and oh yeah, do that, right? I don't even do that for the most part. When therapists come and ask me questions, tell me what to do. I don't know you. I want to know you. I want to help you. I need a little bit more information. A little bit more information to give you the guidance and the right advice versus just like, bleh, saying whatever. Right? But when I say this, your patients are coming on. They're going to the same YouTube channels to learn about flexor tendons as you are, right? If you are like, shit, I don't know what to do, they on the same channels. So you have to step up your ability to critically think, problem solve, and make decisions that give them value, that really give them value, that really help them, right? Because we sit here, we talk about flexor tendon, pulleys and cruciate ligaments all day, but if you don't know what to do with that information afterwards, and they don't know, it's like two Black people getting together and not knowing what to do, right? So I hope this has helped you. I hope this has motivated you to really kind of step up your game a little bit. Know, okay, 100%. I'm always like, know that it's possible for you to be able to do it. I want you to know that you have the ability to be able to specialize and to be able to treat any kind of flexor tendons that come your way, right? Any hand case that comes your way, I know that you'll be able to do it, right? Hey, Betsy, so nice to see you. All right, thank you so much, everybody. Amanda, thanks, fan of demo. All right, awesome. Who else came? So everyone who came on to watch us here, thank you so much. Do you have any last minute questions before we wrap it up? Drink some wine. What are you guys doing for your Saturday? What are you guys doing for your Saturday? I'm looking out at the beautiful pool and at the beach. So if I can take a moment, my husband and I did a thing this year. We did a thing this year. And we bought an investment property. So that's where I currently am. Bought an investment property, well, a lifestyle property too, you know, something. My kids are older, you know, my kids, I have a 14 and a 12, and they're getting kind of big. They're getting kind of big, and they're getting to the point where they don't really want to hang out with me as much. They're getting to the point where they rather, you know, hang out with their friends. Like my son was like, I don't want to be there. I want to hang out with my friends. Like, you know what? So sorry. You hanging out with me this weekend, right? So a little forced hanging out with their mother. But yeah, we're renting. We're, you know, working on fixing it up. Uh, we're working on fixing it up, and working on getting it rented and stuff like that, so more and more people can come and enjoy this beautiful place. We love it. I love it. I love the ocean. Um, I love being here. It gives me a lot of peace. Lets me think. Let me think. Let me think about like how I can, you know, develop my programs and help more people. Melinda is sewing and decorating for Halloween. Bless your heart. You know, my mom wanted to show me how to sew when I was younger, and I wanted nothing of it. And then at some point, being in my, like, I think it was like my late 20s, where I wanted to pick up sewing. My mom, and I went to her and I was like, "Can you show me how to?" She was like, "No, I'm not showing you how to sew. That time has passed." Well, my mom used to love sewing me clothes, and I wanted nothing of it because I wanted to buy my own clothes. Now hear me trying to sew my own stuff. She was like, "Nope, nobody got time to teach you how to sew now." Yeah, I love that you're sewing and decorating for Halloween. My assistant at the clinic already decorated. She already decorated the office. She was like, "I'm gonna decorate for fall," because I told her Halloween was a little too early in September, because she wanted to decorate September 1st, and I was like, "That's a little too early." I was like, "You can decorate for fall." I literally had one fall item, one fall. So she just decorated for Halloween. So, oh yes, you should show me. Show me what you're doing. Tag me on Instagram or wherever you want to tag me, and show me what you did today. I'm so glad you found us too. It does help with their orthotic fab skills. So I'm kind of I'm creative. Like I make jewelry. I'm not necessarily like a draw like an artist. My daughter loves drawing, but I'm very good with my hands. But I do know how to sew a little bit. So there's this new orthosis book, right? The new edition of the orthosis books, which I had highlighted like a few weeks ago, that was written by some CHTs, and Marianne and Noelle. They asked me to contribute on orthosis, and the one orthosis that I contributed about was one that I sew. There's an orthosis, an ulnar. It's an ulnar gutter. No, I'm sorry, it's not an ulnar. It's an ulnar drift orthosis, and I sew that orthosis because I don't like the stuff that's out there, and anything hard for those type of people who have ulnar drift, right? So yeah. So very cool. Thanks for watching, you guys. Yeah, so I'm gonna go enjoy my Saturday. I'm gonna show you guys some pictures. There's some pictures in Instagram of our little beach oasis that we call Sunrise Cove number 6. And it's because from the balcony you can watch the sunrise. So when you see me posting sunrises, I don't know why I became an early morning person, but I like to wake up and watch the sunrise. So yeah, very cool. Thank you so much. Thank you everyone for joining. If you have any questions, feel free to message me. If you are interested in any of the programs that we have, you can go to handtherapysecrets.com and take a look at those. If you're on Instagram, go to the link in the bio. Or just trying to, if you like what I'm doing, please consider sharing it with your other friends. In the therapy world, a lot is done by word of mouth. So just by sharing that 1 or 2 stories, or just by sharing, if you see a really cool YouTube video that I'm constantly trying to put out once a week, then share with your other OT friends so they can get inspired, motivated to become an expert in their area. All right, guys, thank you so much for joining. Have a great weekend, and I will talk to you soon. Bye. End broadcast.